dear faculty members and the audience. The subject that was sort of asked by Dr. Anil Jain for me to speak on is basically to differentiate what exactly we are doing, which is mostly knowledge-based, versus what Dr. Venus told, competency-based training in orthopedics. And so the objectives for my talk is to understand the basic differences between the two and see how they differ in terms of its basic principles. Now, medical education has a history of tinkering with the curriculum endlessly without realizing larger educational objectives. Now, medical schools have yet to create a true learner, a learner-centered environment and self-directed learning under the close tutelage of interested faculty members. Now, we want to, most of it Dr. Shantaram Shetty has covered, how we want the orthopedic surgeon of the 21st century should be effective in medical health communication. He should be good at clinical skills. He should always practice evidence-based medicine in terms of diagnosis, management, and therapeutics. He should be a lifelong learner, and he should always do things to the social and community context. And the main goal of postgraduate orthopedic education is to create a model specialist who is competent in terms of global standards, in terms of education, research, and healthcare. Now, we have a lot of gaps here. They're creating an orthopedic surgeon for the future, no point in teaching them what we learned as students. There's a large gap between the education and the healthcare sector. He does not get himself trained in the type of problems that he sees in practice. There should be some changing educational strategies, and there is a need for a structured PG curriculum. And orthopedic surgery also has evolved over the years. From a subdivision of general surgery, now we have got subspecialized areas like arthroplasty, revision arthroplasty, arthroscopy, oncology, and things like that. And whenever we think of tinkering with curriculum, it is important that it is not only the faculty or the deans who sort of decide about it. We need to take into account all the stakeholders, namely the society and the community at large, the patients, the residents, the faculty, the administrators, and the medical educators. There are different types of curricula that are available, but I'm not going to dwell into each one of them. The apprenticeship model is the Guru Sishya Parampara, which obviously cannot be done now because we are expecting almost 1,500 postgraduates to come every year, and we hardly have 500 teachers. So that means 1:3 is the ratio that we have, and the apprenticeship model really doesn't work. Discipline-based, yes, we can follow it, but the present tendency is to go for the modern car, like the competency-based, and so I will deal with those aspects. What is the basic difference between the traditional curriculum or the knowledge-based curriculum and the SPICES model or the competency model is that the SPICES model is student-centered, it is problem-based, we are dealing with individual problems of an individual case and learning the basic science as well as the clinical science as related to that. Whereas in the traditional knowledge-based one, it is mostly teacher-centered, it is information-oriented. Collection of information from various resources is what is done there. It is not very integrated, it is mostly discipline-based. It is not oriented too much to community, but it is mostly tertiary care hospital-based. There are not much chances for electives. Even in the postgraduate education, we do not allow too much of electives to be chosen by the student, and it is usually uniform, and it is not systems-based, more apprentice-based. Knowledge can now be acquired from various resources. E-resources are very much available from webcast and telemedicine and whatever you name it, it's possible. But competency-based development needs an institutional environment. That is why most of the institutions should concentrate on this. And from a level of learning more and more about knowledge, we should move into an inverted triangle where the competency should score over, and knowledge is something which people can always get from any resource, and while moving from a novice to an expert, he should be more and more competency oriented rather than a knowledge oriented person. These are some of the postgraduate course objectives. I'm not going to read out, but just to say that he should be aware of the current concepts in the quality care of an orthopedic or a traumatized patient. He should be able to offer initial primary treatment as soon as he completes his MS. He should have some sort of introduction to research methodology and to do some sort of a research, and he should be in a position to refer the patient whenever it is required from the place where he sees to a better center as and when it is required. He should be able to effectively communicate to the patient and his relatives. He should be able to exercise empathy and a caring attitude, and he should be able to continue to evince keen interest and a lifelong learning in the subject that he has taken. Now, what is this word competency? Is it just skill? Most of the orthopedic postgraduates would say just doing a DHS or doing a DCS is all that he has to learn. But it is not just psychomotor skill. Is it knowledge alone? It is not knowledge again. Is it capability? Yes, to an extent, innovate and capability is important. Expertise or attitude. But out of the various definitions that I went and looked up in the literature, I found the Epstein's definition to be the most appropriate about competency. It is the habitual and judicious use of communication, knowledge, technical skills, clinical reasoning, emotions, values, and reflection in daily practice for the benefit of the individual and the community being served. So you can see it is not only skill, it is almost 8 different components that he should become competent. And that where does this competency actually come in a road towards mastery? We all call ourselves masters, but actually competency comes at the 2/5 or the 1/3 distance of the road towards mastery. So it is much, much earlier, and many Western universities are talking about competency-based education at the undergraduate level rather than at the postgraduate level. So what are the various competencies that we are expecting? Apart from medical knowledge, he should be able to give adequate patient care. He should be able to behave in a professional way. He should have excellent interpersonal and communication skills. There should be evidence-based medicine that he should be able to practice, quoting some sort of a literature for every type of treatment that he does, and some amount of research activity should also be possible. So you define the competencies, you also give the appropriate instructions towards that, then you do a formative evaluation and a feedback. The most important component of any competency-based education is the time that you spend with the student in order to give the feedback. A continuous effective feedback to the students will develop the students much more than the summative assessment which we do, which is detrimental to his future. Once he fails the final exam, I think he loses almost quite a lot of his esteem. And this is a master chart that one can work when you are doing a competency-based curriculum. You define the competency, then define which domain it belongs to, whether it belongs to the knowledge component, the skill component, the attitude, or the communication skill. Then you put in what level of the Miller's pyramid. Does she have to just know, or does he have to know how, or does he have to show the procedure, or does he have to perform? So define that, then see also whether it is core, yes or no, and then suggestive teaching learning methods, and then the suggesting reading that he has to do, and also define whether it is absolutely important for somebody to be certified before doing this. The duration of any curriculum is very important. Ours is the only country where, due to economic reasons, we have based our postgraduate program just for 3 years. But if you see all other countries, it ranges from anywhere between 5 to 8 years before somebody is called a specialist. Now, patient care, this is one of the important competencies, and what does he have to know? He should be able to demonstrate an ability to obtain a comprehensive and focused history, and demonstrate an ability to perform a comprehensive and problem-focused physical examination. Information gathering is something very important. They should be able to resource the data and also be able to collect information of the patient and document them well, and that is the area that we need to also work on. Now, this is the component that all our postgraduates are very careful, the surgical log, the procedures that they have done. They must demonstrate the ability to perform certain specific procedures, but that is not all in all. And even in that, it is always the high end of fixations that they are more interested rather than the plaster technique or something that they should be competent with. How do we assess the patient care? We can do it by the long case or the short case presentations. We can do it through OSCE. We can do through incognito standardized patients, and we can also do it through global rating or checklists that Venu mentioned about. Medical knowledge is something which we are already overloading them, but this is something which you have to define as per the competencies that they should acquire, and this can be assessed by means of MCQ, essay question, OSCE, or by an oral examination. Professionalism, this is something again you have to define what exactly do they mean. It is something like taking personal responsibility into the care of the patient that he does. He should be truthful and honest. He should have certain, and the personal beliefs and prejudices that he has should not be imposed upon to the patient, nor does the personal beliefs and prejudices of the patient be completely interred with. Now, these are some of the characteristics of professionalism that he should exhibit. Confidentiality is another one which you should maintain, and this can be assessed not by means of his own professor or somebody. It will be invariably the nurse or the paramedical workers with whom he works who will be able to give you information about this particular competency, whether he has developed it or not. practice-based learning, this is about literature review and how exactly he is able to critically evaluate medical literature to the patient care that he does. It is not just quoting some journals here and there. How exactly he relates the literature to the particular problem that he faces is very important. Demonstrates his interest in medical research, demonstrates enthusiasm in the educational process, and this can be done by journal club sessions and by seminar presentation and there. The communication skill, everybody thinks it's speaking, but there is a very big skill, the written skill. How exactly he documents a reference letter to another consultant, and how exactly he sort of writes down case summaries and case histories or discharge summaries. That is very important. And so it's not only speaking but writing, and also a visual image that he is able to get in order to have this particular competency, and it can be tested by seminar presentation, oral examination, or something called the mini clinical examination, which again in the Western countries they will be, yeah, I'm just finishing. System-based practice, you know that our patient care has become very complicated now. We have got a discharge process, we have got a theater room process, we have got a admission process. So the student also has to understand that he has to work in different type of conditions, and this can be also assessed by an oral examination, standardized patient assessment. Academic skills, of course, I will not dwell too much into it. The dissertation many times brings out this particular strategy. These are some of the new educational strategies that one can look into, and this does not have to have the student and the teacher sitting just opposite to each other. They can be done many times online between the teacher and the taught. Now, the traditional lecture method teaching is often teacher-oriented, and the students do not have much of active participation in that, and usually does not lead to clear development of student skills. And usually the learner-centered method should be able to allow the student to do it at any time, anywhere, and any number of times. So these are some of the things that one should keep in mind, the advantages as we. Now, I just would end by saying that what Albert Einstein said, I never tried to teach my students anything. I only try to create an environment where they can learn. So this should be the motto of most of the teachers, who should rather become facilitators rather than becoming demigods. The learning management systems, now these are available. The computer world has come out with a lot of newer ideas. The delivery of student assessments can now be very critically evaluated and given back. Tracking of learning progress, virtual classrooms, virtual operating rooms, virtual emergency rooms, these are all in place. Some of the institutions which can afford that, you can give the student the training which he may not face in a sort of a contrived situation. And in conclusion, I would just to say that we sort of had a bird's eye view of what is competency-based education, which is being followed both in the US as well as in the UK, and how we could introduce some of these changes into our own curriculum. Thank you.
Thanks, Dr. Vijay Raghavan. I think we're just going to change this order a little, because this knowledge-based, competence-based, I think then let's put this apprenticeship model of training first, weaknesses and strength, and how can we balance that. Mr. Karthik Hariharan.
Chairpersons, ladies and gentlemen, I talk to you from an experience of 15 years being involved in a small way in the evolution of the then apprenticeship-based model of training in the United Kingdom. So I will speak from a pedagogical point of view. It is as old as the hills. The traditional models have been practiced for millennia, and it was the classic way that a craftsman learnt his trade. This is Sir James Paget of Paget's disease fame, who practiced with a general practitioner for 5 years, but he had to pay the general practitioner 100 guineas, which was an astronomical sum of money. And he described his experience as rewarding, but because he was left to himself, it created in him an unusual disposition for learning methods and scientific observation. So he actually imbibed that rather than it being sort of inbred or cultivated in him. We have to define what training is and what education is. Sometimes these are loosely used terms. Well, training, which forms the apprenticeship model largely, is a sequence of instruction which has been taught down the ages. There is supervision, and to a small extent there's some feedback. There is subjective assessment, and these assessments are for very specific skills. And what is actually being assessed is technical competence. It sometimes aborts and stunts critical thinking because you're doing exactly what your boss is doing, but it allows you to become competent in dealing with familiar problems. Whereas education is a much broader concept, where there are specific learning objectives, but there are strategies to achieve those learning objectives. What it really encourages is critical thinking, lateral thinking, and it also trains you to be able to solve complex and uncomfortable problems on occasion. So if we looked at traditional models in orthopedics, there's often a statutory framework, and the boss, the consultant orthopedic surgeon, is the expert. And the student, which is the orthopedic trainee, will follow his specific consultant. And the consultant, based on how he feels about his trainee, will allow an increasing degree of independence, and at the end of it will give him a certificate of competence, such as a diploma or a degree. It's an excellent vocational model, and through the years has bred countless surgeons. So this is the classic traditional apprenticeship model, where the student models himself on his teacher. The teacher coaches him initially, and then works like a scaffold, scrubbing up with him and helping him to operate, giving him increasing independence, but eventually just shadows him, sits in the operating table, in the operating room, whilst his student is operating inside. Unfortunately, the traditional model is based on several presumptions. The first presumption is the teaching consultant is a very good teacher. The second presumption is the trainee is a very good trainee, is able to absorb everything that the teacher says. The third presumption is that the techniques are good enough to cope with the requirements of the present day. And the last presumption is if the student is as good as his teacher, that is good enough. What are the strengths of this model? It's an excellent vocational training tool, as I said. It has bred thousands and millions of wonderfully qualified trainers, teachers, consultants, and surgeons. And there are occasions when it is actually adequate for current provision of services. In emerging economies such as Africa and some parts of the Far East, it is actually adequate for the provision of services. But there are weaknesses. A lot of the assessment systems that are in place currently with the traditional model, they're all subjective. It does lack format and structure because of the enormous number of confounding variables, the varying technical abilities of various teachers, etc. The biggest problem in a country like India, but also to a large extent in America, is that there are only a limited number of faculty, there are a limited number of teachers whom you can send these students to. There is often a lack of the multidisciplinary concept when you're training in a pure technical capacity. And occasionally, if your teacher has got a bad habit, you will get it too, unfortunately. Because it's over-reliant on a lot of these assumptions, there's no validated standards of training. So each institution may have its standards, each region may have its standards. There's no scope for reflective or interactive thinking. So you and your boss can't go out and have a beer and talk about medicine, and it does sort of limit your ability to do that. There is also a significant problem in that, as mentioned in the earlier talk, that it doesn't keep pace. There are lots of establishments which either cannot afford to keep pace with global orthopedic progress, or simply don't have the interest in doing so. They're comfortable in their own little universe. And most important of all, research is not incentivized in traditional models of apprenticeship. So, in summary, if you assess this using these parameters, apprenticeship models provide training, but not wholesome, rounded education in its current format. So what can we do to tinker with this process? I mean, change is necessary. And I think the biggest change, unfortunately, has to be a culture change. It's a change in the collective conscious thinking of the orthopedic community in any society. This is the significant difference that we need to bring in. We need to bring in articulation, being able to speak freely with your boss, questioning what he does on occasion. You need to be able to have the opportunity to reflect on your practices, discuss whether what you have done today is the right thing, or whether you need to move it or change it. And you also need to be able to explore other venues. You need to be able to innovate. And how can we do this? I mean, there are several methods of doing it, but you need a foundation. We need to try and create a framework of nationally agreed standards. There is a hub and spoke system that's currently available in the United Kingdom, and I think that's working very well, although not completely well, which is the creation of regional educational deaneries, which you could use to supplant what is a central agency. I think we spoke about the increase in training time, and I think that's a very expensive proposition, but I think it's a very necessary one in order to get that rounded quality to the training. The role of the national institutions in the UK, the British Orthopaedics Association and the Royal Colleges, play a pivotal role in driving this. So it's a live document. The curriculum is a live document and changes every 3 or 4 years. You do need to have a patient-centric system of training, and you may have to use local training opportunities, public-private partnerships, etc. And as I mentioned earlier, the outcome-based assessment is a far better and a more validated system of assessment. As in-training assessments have been followed for the last 12 years or so in the United Kingdom and have proved very successful, learning opportunities, as mentioned before, are extremely useful. Web-based, case-based discussions, procedure-based assessments are very, very useful. Very, very important for your trainee to have learning time. He needs to have protected learning time. Most deaneries in the United Kingdom will have every Friday, for example, off for the trainees in the afternoon to go to a co-curriculum teaching program. And that has proved extremely useful and important. And there are, I'm not going to harp on about the subspecialist training because it's already been done, but appraisal and revalidation for the trainer. Training the trainer is very important. Newer and more innovative methods of training to be taught to the consultant is very useful. You need to, we've spoken about probity and transparency in your practice, and that should be actually encouraged and assessed. You do need to also learn self-appraisal and critique, and audit is an essential component of the curriculum of the United Kingdom. In conclusion, you need to provide both education and training based on local needs and requirements, and a central educational authority is pivotal in trying to govern the concepts of education as we know it. You need to use validated assessment tools which will plumb the length and breadth of training in modern medical practice and will also offer the opportunity to create lateral methods of training. Thank you very much.
Thank you, Dr. Karthik. Now I think we move on to the next talk, and this is going to be by Dr. Bijoy Singh, and it's an important component, and Dr. Shantaram Shetty mentioned about record keeping, and one of the methods of doing this is by logbook or by a portfolio maintenance, and may I request Dr. Bijoy Singh to give his talk.
Thank you, Chairman, ladies and gentlemen. At the outset, I would like to take this opportunity to thank IOA and the local organizing committee to give us this opportunity to talk about how to improve training. When I was given this talk by Venu, I thought if I was a trainee or a trainer, what would I need to sort of know? How does this change? And as previous speakers have mentioned how the training has evolved. So what I'll just briefly talk about the evolution of training and how does the e-logbook or the work-based assessment as broadly we should talk about rather than just the surgical logbook, the advantages and disadvantages both from training and the trainer's perspective, and some conclusion. So just broadly describing the training, historically it used to be what has just been discussed about the apprentice-shaped model where the trainee spent time with the trainer and eventually the trainer said, yeah, you're cooked, ready to go, and there we went. The current training has got time constraints, limited resources, and puts more demands on both the trainee as well as the trainer, but I guess that is where we have come to, and we've got to learn to adapt how we do this. Why has this come along? If we look at one of the reasons is the time. The European Working Time Directive, which is pretty strict, in the 50s and 60s, the working hours were about 80 plus hours, and the trainee went through different stages of house officer to a senior registrar before they become a consultant. In the early 2000s, this was dropped down to 56, and currently it's 48 hours. So, and that includes the on-call time. So we've been forced to look into evolving our techniques, how we produce trainees who will be capable of performing procedures independently. Interestingly, in US, traditionally it was over 100 hours per week. In 2003, their academic body said it should not be more than 80 hours. But a recent study showed that some places it's still about 88 hours. The problem is it's not regulated. In my own experience training in India about 20 years ago, 1 in 3 on call, and this is roughly as a first year resident, 104 hours is what roughly I said this is, not including the 24-hour on call cover. So that's how it's changed. In the UK, we use 2 different resources. One is the Intercollegiate Specialty Curriculum Program, which I'll describe in a minute, as well as the e-logbook. They both go hand in hand with each other. So what does the ISCP say? As discussed previously, there's 5 elements to it. One is the case-based discussion, which evaluates the patient management in-depth discussion about that. Clinical examination skills, so appropriate level. DOPS is mainly at a more junior level, so simple things like application of a plaster or aspiration of a joint. Procedure-based assessment, or the e-logbook, is where I'll focus most of my talk, as well as the multi-source feedback, which has been mentioned in the previous few talks. So just taking you through an example of how this procedure-based assessment works. So this is what the trainee will send to me, and that's the procedure. Operative fixation of a Weber B fracture of the ankle, with me as the consultant, where it was done and the date when this was done. So there are 6 parts to each PBA, and this is used for majority of the procedures that we do. Consent, pre-op planning, pre-op preparation, exposure and closure, Interop Technique, as well as post-operative management. So this is what the trainee will say: consent, whether it demonstrates the knowledge, awareness of sequelae, as well as other likely outcomes. And then I get a comment to put where he said, has seen the patient on the ward, explained the procedure to include the post-operative risk and rehab, and also discusses why the surgery is needed, and also if there are any other options. Pre-op planning is where the trainee would look into the technical aspects, so look at the blood test, investigation, fasting, and simple things like that, imaging, whether they've been marked. And then into theatre, now we have a WHO surgical checklist, which has become more detailed. So, I mean, until a few years ago, that wasn't that mandatory, but now it's become, so you have to check the consent, do a proper team brief to theatre as to what you're going to need for this procedure, and how you're going to undertake it, and going through all the pre-op checks, imaging where the radiographer needs to say, and then he would say the N stands for not noticed, unsatisfactory, and satisfactory. So this is my comment saying does a proper team brief, explaining instruments and implants that are needed, talks to the anaesthetist about the requirements, and also the radiographer, their role and how he likes it to be positioned. Then the Interop Technique. So this is a bit quite a busy slide, but essentially it takes care of most of the steps as required for a specific surgery for the ankle, to demonstrate use of lag screw, whether, if that is going to be necessary, sound technique for knots and sutures, handling bleeding properly, as well as handling soft tissues. And then again, time for the trainer to make a comment. Failed to identify the butterfly fragment on the lateral malleolus, which was not seen on plain radiographs but dealt with effectively. Need to be aware of time changes, and because he was moving slowly, you've got to make a comment on that. At the end, we write the post-operative management. Most of us are now doing a printed sort of typed op note, so it's clear, so nobody can say that doctor's handwriting, nobody can read about it. And then also writes proper post-op instructions for the patient. And then finally, there's 4 levels of skills that you can say. Level 0, where there is insufficient evidence observed to support a summary judgment. Level 2, unable to perform the procedure or part observed under supervision. So this would be sort of for a year 1 trainee who has just become a registrar. This is further on, able to perform procedure and then perform with minimum supervision, and able to perform procedure and could deal with any complications that arose. And after that, there's a brief reflective summary, and this is what the trainee has said. long lateral fragment, first laxative applied, difficult applying, second laxative is required, assistance from consultant. So this is what the competency-based thing is. And that, once that part is done, then they put this into what's called as the e-logbook. And essentially, every trainee is required to submit between 350 to 400, am I correct, Venu, per year. If they're not getting up to that, then they don't get signed up for that year, so they have to redo that training. So it involves sort of patient details, when it was done, the type of surgery, ASA grade, who was the consultant, and then supervision code, whether they were assisting, performing, just observing, or undertaking it independently. And there's a list of commonly performed procedures that is there, and one can search for other procedures as well, and where it was performed. And the trainee also gets an opportunity to make some comments about the procedure, as well as if there are any intra complications. At the end, they get a summary like this. So this is a page view to see what was done when. Sorry, this is my page. The trainee would get something similar. And if I have, so that would come to me. If I have validated that procedure, then at the end there is a padlock which suggests that this procedure has been validated by the consultant. They can also produce various reports. So just as Venu was showing, so this is a specialty trainee year 3, 4, 5, 6, 7, 8, and the procedure is intracapsular hip fracture. So from year 3, where he was assisting, and that's national and trainee, where they were assisting more, to year 8, where they are doing most of the procedures themselves independently. It also gives a summary like this of various aspects. So this is all the trauma cases from ST3 to ST8. So going from that number where they're assisting more to performing the procedures independently more. So what are the positive aspects? I mean, it has to be a trainee-led. There is no doubt about that. It cannot be a trainer, shouldn't be running around. It has to be evidence and discussion of cases, evidence of procedural assessment, as well as multi-source feedback. It also helps record any non-clinical activity, which are these sort of research, audit, teaching, as well as managerial aspects if some of the trainees are involved in that. Negative aspects, it obviously takes time. So both the trainer and the trainee need to have time where they will be able to assess this. Hopefully it's not seen as a tick box exercise, and also, I mean, having spoken to the trainees, it has to be done prospectively. I mean, there's a paper published where this, often trainees at the end for the logbook go at the year to the theatre logbook and find what they have done, and that's always inaccurate. There's financial implications if it's going to be a web-based program that will need to be developed. And hopefully it should not detract from the learning aspects, although there is potential for that. So, what the trainees require now is what I describe as work-based assessment, which involves case-based CBDs, KECs, DOPs, PBAs, and they're expected to submit 80 assessments a year. If they don't, again, they don't get signed up for that year. So, in summary, I think we're coming into a new era where there's lots of teaching and training evidence-based. It's going to be competency-based rather than apprentice, and surely this will evolve with time.
Thanks, Vijay, for nice presentation. I think now we'll move to skill lab training. Does it help? And this will be delivered by Professor Naresh Shetty. Dr. Sundaresh has not come, but yeah. Dr. Naresh, please. I again make a request to the presenters to give the write-ups within 1 to 2 weeks' time, so that we can compile them as some document.
Actually, the Sachin Tendulkar is not come, so I'm like a Rohit Sharma. I hope I enter issues. I don't know. The first match did not show that. Anyway. Psychomotor skills training in orthopedic, does it help? I think every time you sit on a flight, there are two things that you always expect, that flight will reach in time and the flight will reach safely. I think the same thing is perhaps decided by your patients also, whether at the end of the day, whether he is going to get a good surgery done and whether he's going to be alive. So I guess knowledge is just not important, training is as important as well as critical. Both surgeries and aviation are both highly risky job. And not only they are expensive, but what is important is training. The critical part is only training that comes in. We have been talked about historically by Hippocrates, as you are trained, so you should train. There are so many people, stalwarts who did speak in before me, and they spoke about different varieties of things that could have been done. We were following a certain model, but the question now today that has been asked is this enough? And if at all, if it's not enough, should we change? And are we really keeping pace with the need of the present era? And just giving on-the-job training, is it safe at all? When you see this slide on the right, everyone would be having different aspects in their mind. Each one would be thinking differently. But I think to get into a yogic pose with a definite expertise requires a lot of efforts and training. And I think that is our current problem. We have more than enough postgraduates, but the training program is not enough. The curriculum is too vast for undergraduate. Psychomotor skill is not at all defined at all. Post-graduation qualification, well, less said the better, and a demand for minimally invasive surgery. We have this habit of putting the cart before the horse, and now we have so much burden, neither the horse nor the cart can take the burden. The regulatory bodies have been there for many decades, and yet we're not sure whether the right things have been done. There are no clear definition of motor skill training, type of skills, number of hours to be trained. In March 2011, MCI came with a Vision 201 statement, and they talked about three things: skill development and training, certification of skills, and adoption of contemporary education. Unfortunately, all these have been talked about, but still not reached, and we are just going to cross 2013 and go entering 214. The Vision 2015 also recommends for PGs a skill center where this will become mandatory. This would help many disciplines to improve the quality of training. How far have you reached this goal? I think all of us know about it. Natarajan did say, if you read the Indian Journal of Orthopaedics, and he is very much here, that the skill development centers and cadaveric labs should be made essential to the entrant postgraduate before he can lay hands on patient. And he came in the right moment when I'm going to put his slides on. That's what timing is all about in life. So what is quality healthcare? We need to be care that consistently contributes to improvement as well as maintenance of quality. And this could be done by evidence-based practice, implementation of continuous quality improvement techniques, and use of outcome determination and management. All of us know, and everyone talks about protocols, and everyone talks about use of prophylactic antibiotics, post-operative anticoagulants, and physical therapy for gait training. But please let me know, how many of these institutions in our country follow the same protocol? I think the Indian Orthopaedic Association must set up the protocol now so that this could be followed by every other centers. And that's what it's all about, putting things into proper perspective. Association of Surgeons in Training have got, and if anyone has looked to their website, have facilities for training and simulation surgical training. And that's, I think, a realistic expectation from every orthopedic surgeon. What is it? To restore form and function to the maximum extent possible, practice evidence-based medicine, and use minimally invasive techniques. If you looked at patient safety, NHS Litigation Authority last year, total number of claims 292, orthopedic was 30%. And in the largest database of patient safety incidents growing at the rate of 9 lakhs every year, the orthopedic or trauma stood at 32%. So what we are expecting, and healthcare should be safe, effective, patient-centered, timely, efficient, and equitable. An in vivo technical skill transfer, a randomized control study, what did he say? that this is a three-stage sequential process, a cognitive, associative, and autonomous. And with practice, the learner transitions to a final stage where the correct execution takes place. And the conclusion was, this study showed that relatively short duration training on inexpensive, low fidelity synthetic bench top simulator resulted in improving both technical and cognitive performance in the operating room. A virtual reality simulation for operating room proficiency. And what did the template propose? A didactic teaching, instruction on steps on the task procedure, defining and common errors, test of all previous didactic information, technical skill, provide feedback, provide summative feedbacks, repeated skill training. And what does it mean? Why does it require? Because the society demands a greater accountability in medical performance and professional requirement. And this is uniform in Europe, United States, which are the major driving force. We need to optimize patient safety because that's the only consideration that we are all here. Another medical discipline would do well to look at the MI surgery community for lessons learned, opportunity missed, and the current achievements. We need to stop monkeying about and talking about errors. The errors could happen only because they are either human related or equipment related. And both are within our parameters, and we should be able to correct it. We need to shift the culture surrounding medical errors from one of blame to one of understanding and prevention to the mutual benefit of patient and the surgeons. The solution is need for post-MS training, defining core components for 3 years PG training, training of teachers, and define psychomotor skill training. The challenge to achieve this is to introduction of high technology instruments, implants, minimal invasive surgery, subspecialization, higher demand for quality, and always not forgetting that patient safety is of paramount importance. What can we do? Change curriculum to suit current needs, structured training to address development of motor skill, simulated learning, surgical exercise in anatomical specimen, on-the-job supervised training during patient care. We have moved from formalin-preserved cadavers to actually chemical embalmed limbs, where the limbs move as much as the normal ones. Our cadaveric lab, I think many of you have visited there, and if you have not, it's a place to visit. We have what is known as a voluntary body donor program, which is known as the Live Well, Leave Well. That means LIVE well and LEAV well, where about 300,000 people have registered now up to date, where they have donated their bodies for the cause of learning. We have 16 workstations with the cadaveric lab and with a 2 workstation research lab. That's how our cadaveric lab looks like. We have used preservation method, which there are different kinds of that, but we are following what is known as an MSR technique, where whenever you use that body, it is as supple as that you want and as flexible as you require. The preservation objective is to retain the organoleptic properties, permit repeated use, storage capacity of 60 cadaver specimen, we have it, and to delineate vascular anatomy. This is how near normal the cadaveric lab looks, the specimen looks like. We do also injection of brain sometimes to do the vascular patterns. But these applications are useful more importantly for orthopedics in their arthroscopy, spine surgery, arthroplasty, in plastic surgeries, gynec and other areas, neurosurgery, general surgery and ENT. But who are going to be the beneficiaries? The medical students, the postgraduate students, surgeons aspiring to specialize, train in special procedure, researchers and industrial implants. We have been running numerous courses, and I think almost 59 courses from last year. But what are the parameters for feedback are the cadaveric quality, which we have taken from people who have participated in this. And each of these parameters over a period of time, we did go through it to ensure that we are rectifying it. We also have a junior research lab. And the thing is, all of us talk, but I think we have done what many of us perhaps could do is, number one is to have a cadaveric lab and a skill lab. And number two, we have now R&D, which is placed within the hospital, where you have 8 engineers who work with different specialty to come up with innovative, frugal innovations for our country. And that, I guess, is perhaps the way to go. We have a multimedia center where we have a video conference and a webinar, and I think we do ensure that many of our hands-on workshops that are there are shown across the globe for many of these things, and a lot of companies have shown a lot of interest to come forward to sponsor this event. The question that needs answer is acquiring cadaver for education and research. We need to have policies to be reviewed and promote cadaveric donation. We need the industry definitely to promote training, because there is no other way, absolutely. And resource sharing. It is not easy for people to develop this skill and research lab. It takes a lot of time and effort, lot of money, and more important that you need to get the cadaver. So I think we are ready to come forward and said, let's share our resources. And I think we always said to the Indian Orthopaedic Association, you can have any one of your program there, we are there with you. Thank you. And I think that was the vision that our chairman said, progress or perish. And I think if at all we need to do that, we need to look forward from what we are doing to what we should be doing. Thank you.
It was wonderful presentation and double. Now next we'll be talking about super specialty training. Do we need some different changes and some protocol? And who better than Rajashekharan to talk about it?
Good afternoon to all of you. I have a disclosure to make at the start that probably in front of pros chancellors, vice chancellors, almost everybody sitting is dean or deanery. So I feel a little bit delicate to speak over here. But just to bring 3 or 4 salient points, and perhaps I'll finish quickly so that we can have a discussion about it also. I think in our country now, when we are at crossroads, where India is not being considered just for training Indians, there are lots of people from SAARC countries and African countries coming here for training. We really need to have good definitions of what is specialty and who is controlling these specialties and what will be the specialty training needs. Now, specialty itself, or the term super specialty, is very difficult to define, because when you travel across the globe, you find there are different definitions for it and different applications for it. For example, an oncology surgeon in India, it's enough if you learn the principles of ablative surgery and removal and clearance of the tumor, because you also have in your team always a reconstructive person who is aiding for you. But when I went to Munster, it seems the oncology surgeon there has to pass through 3 years of reconstructive surgery. He passes through plastic surgery. So it is the same surgeon who not only removes but also reconstructs. And so there is a vast difference in the requirements of your super specialty. In head and neck surgery in our country, of the 2 major institutes that you see, Tata Memorial Hospital, the orthopedic surgeons and the ENT surgeons and the head and neck surgeons are involved only in removal and clearance, and the plastic surgeons are involved in reconstruction. You move down south and come to the next biggest center in Amrita Hospital. It is a single surgeon who removes and also reconstructs. So he works through the whole day to get it done. And both keep arguing for the plus and negative points of it. There is also a vast difference between who controls these specialties, and that gives a different flavor to the super specialty training in our country. In our hospital, hand surgery, for example, is completely controlled dominated, I would say 100% by plastic surgeons. And then the nature of training is completely different from a person who is training under Sudhir Warrior as a hand surgeon in Bombay, or with Professor Kotwal in AIMS, and then their pattern of training becomes completely different because they are orthopedic oriented and orthopedic surgeons. So I think we really need to sit down, and when we say super specialty in each of these groups, what exactly will be the curriculum and what will be the needs of the trainer and what will be the syllabus, and that will be the first step that we have the major challenge. The second question that we have already been debating is, do we need super specialization in our country? Now, I remember one particular event when I was in second year medical college, which means that it's about 30 years now. there was a symposium in the topic of preventive pediatrics. And one of the directors of pediatrics who came to inaugurate the session actually told, very surprisingly and shockingly to everybody, he said the need for the hour is not to discuss preventive pediatrics, but how to prevent pediatrics as a specialty. Because in his opinion, he thought there is no need for a specialty called pediatrics. Now 30 years hence, we will think that it is this. But on the other hand, I would just like to talk, I was talking to one of our good friends, Aravind Kulkarni, a long time ago, on why he is not attending IOACON, and he said he only attends spine surgery conferences. And last year I asked him why he is not attending spine surgery conference. He said now he has no time to attend, only time to attend minimally invasive spine surgery conference. So it keeps on, border keeps on increasing all the time. And where do you stop this super specialty training, and where do you draw the curriculum over it? Now, what is the time that somebody should start super specialization? We are providing super specialization in a few subjects in our hospital, but we do find one serious practical problem in it for younger surgeons. By the time they finish medical college, they are emotionally burnt out by our curriculum. I think they are emotionally burnt out by the time they pass +2. +2 is a very stressful time. They are emotionally burnt out, and they are physically burnt out by the time they pass MBBS. Their enthusiasm keeps on decreasing by the present curriculum, and by the time they finish MS, they are really, their enthusiasm in life and for super specialty training becomes very less. They are also married by the time. They have 2 children, they have lots of loan for their cars, they have everything. And then the most important thing for them is mortgaging and how to pay the loans and how to come up in life. And to go for 2 or 3 more years of training at fee of training becomes very difficult for them. In UK, it is quite different. I mean, your pay while training is you are drawing a salary, you are not drawing a stipend or something like that. Your salary while training is very good. But here, your training, when you're training, you draw only a stipend, and then it becomes a major challenge for all these people. So we need to address these issues, definitely, if we have to make super specialty training very important for us. In our country, there is no doubt we need more and more super specialty, because the problems we get on the whole are more challenging than what we get in the Western world. There is a huge difference between a clinic in the United Kingdom and a clinic in India. And as we are getting more complicated people, the need for super specialty training is very good, very important. But do we have enough number of trainers for that? That is the major question. And who is to evaluate the trainers? So we need to draw a curriculum. We need to define who can be a trainer. We are all, many of these talks were about how to assess the training. But in India, we also need to have, starting point will be to identify and assess and qualify the trainers. And then will be the next step to assess the trainees. Now, who controls super specialty training? We have 3 bodies here, the MCI, the DNB, and associations like us. So I think MCI has to look after the basic medical training. The DNB is very good for specialty training, but super specialty training, I think it should be with the association. So we have our president-elect here, because the needs and the ground realities for the necessity for training in super specialty will be much better understood and much more defined by the specialists in that specialty rather than by one general committee sitting and drawing over this. So I think it is more important that Indian Orthopaedic Association or the Association of Spine Surgeons of India or Arthroplasty Association or Arthroscopy Association, they all take up this on a primary basis, and we really need to have more advocacy now rather than just looking back and conducting just meetings alone. So these are a few of my thoughts on specialty training, and I'm sure that there are more capable persons over here who look at the administrative side of super specialty training. Thank you very much.
Thanks, Raja. Now I'll call upon Professor Mail Natarajan to talk about teachers training. And well, this is one of the unique sessions that we have two luminaries who have worked as a vice chancellors to the medical universities. So I request him to talk about. And the talk is teachers training. Do we need it?
Chairpersons, senior teachers, colleagues and friends. The very fact that there's a question, do we need it, has to be answered straight away. We have escaped for so long. You all are aware that medical college teachers are the only group of teachers who do not have any formal training. For all, even if you are going to teach the second standard students or something like that, you have to go through a B.Ed program or whatever, and then you have to take a test and then go and teach them. Only medical teachers have escaped so long. Now we no more we can escape, and it is imperative that we introduce it as soon as possible. Now, as you are aware, the moment you finish your MS, you are deemed to know everything about teaching. And then you are put in a medical college. And at least I can tell you, only 25% of the people will, on their own, following teachers and things like that, they will know how to teach, and then they'll form a pattern. But the other 75%, the assistant professors, all follow a rut, and they make things worse because they pass on such sort of attitudes to the next generation. So the problems are being compounded. And under the Medical Council of India, we always keep talking about the Medical Council of India, which was under a cloud for 10 years and nothing was moving there. And we consider it as a sacrosanct body. Now it's not anymore sacrosanct. It is up to us, professional bodies, to take it up, and up to the universities. See, universities also have risen to the occasion, and the overall idea is that medical education has to be controlled by the universities and the specialists in that area, so that we have a better fora rather than bodies which are quite abstract. Now there's a questionnaire survey done by Tejinder Singh, and it published in the National Medical Journal, and it was a study conducted to identify pedagogic themes that should be included in medical faculty development in India. Whether medical faculty or medical education comes under higher education itself is being debated now. Whether it should be separate or it should come under the higher education, there's no way it can come under higher education. It is separate on its own. And if we don't rise up to the occasion, then you will find outsiders going to control you. Now we have already identified that we need teachers training, we need formal training of the teachers rather than the students. Students, of course, basically it is necessary. But if we don't do it, then there's someone else, an outside man who's going to be a lawyer, or some politician who's going to sit on your neck and then tell you do this, do that. This is what has been happening in our country for so long, and it will continue happening if we don't rise up to the occasion. So we better start, have a formal program, call all the experts, sit down and then start it. Now in that study, the themes chosen with highest priority were interactive teaching, student-centered teaching, learning, small group teaching, formative versus summative assessment, providing feedback. Even this, most of us, you see, when you give a feedback form, 50% of them don't even fill up, they just throw it and go away, not realizing the importance of that form and how it can influence further development. The themes continued: assessment of clinical skills, how adults learn. Please remember that adults learn in a different way than children or younger people. So you're all old enough, you're married and all those things. Then your learning methodology, everything is different. So we must understand the problems. Please remember the same thing at different phases of your life are different. Communication skills, group dynamics, problem-based learning, academic, all these have to be addressed, and then we have to form a curriculum and a syllabus. See, in our university, when I was heading the university, there was a big debate about, people did not know the difference between syllabus and curriculum. There was a big debate going on. What is syllabus, what is curriculum? Are both the same or are they different? So we'll have to start off from that level to the teachers. The teachers don't know the difference between syllabus and curriculum. I'm not talking about students. Word curriculum is derived from curricle, meaning a two-wheel chariot drawn by horses. How are we going to reach the goal? The problem is that surgeons of tomorrow are taught by teachers of today using curricula of yesterday. Please understand the significance of what I am trying to tell you. Please read it and try to understand. Because it conveys so much of meaning. See, we get outdated so fast, but then we are not willing to accept it, and we think that what we are doing is correct for the generations to come. No, sir, all that is gone. Now, this was brought about by our JIPMER friend, Dr. Sethuraman. Curriculum is a pathway through which students travel during a course of study. A formal plan of educational experience and activities offered to a learner under the guidance of an educational institution, including the faculty. Not educational institution where the dean and all this thing, it's the faculty, the head of the department, the professors, associate professors, all of us are responsible for this. And it's not a timetable, mind you. Syllabus is subject content in a course of study. Orthopaedics means everything connected to muscle, bone, everything syllabus over. That's simple. But how do we reach our goal? This has to be taught to the teachers. And teachers feel it is not part of their job to develop a curriculum because they have never been involved in this for the past 50 years, since independence. Even when they are asked to give syllabus, they write down a few points and then say, when I took over at the university, I asked them, give me the syllabus. They took out the syllabus when it separated from the Madras University, gave me syllabus to 25 years old. And then the examination methodology, I said, this examination methodology was formed in 1965 by my father. And I changed it in 2005. 45 years later, the evaluation methodology was changed in my university, my state. Can you believe it? In our cars we change every year, except the wife we keep changing everything. Every 3 years, 5 years. Given an opportunity, we'll change the wife also. But you see, in life we don't keep a car for more than 5 years, we don't keep a pen for more than 1 year, but then we are keeping this for 45 years, mind you. This is the sad state of affairs we are in. I am glad that under the leadership of Anil and Vijayaraman is doing tremendous work. I'll come to that. Teachers are not involved in curriculum planning, and curriculum is thrust upon teachers by regulatory bodies and institutions because you are not doing your job. See, if our medical council as well as the state medical council are very vigilant, they take action on the doctors who are doing mistake, then why is an outside man going to take an action on you? We try to protect our own kin and we don't bring out their mistakes, and then you find an outside man coming and interfering in your affairs. The needs perceived by educational experts. Educational experts means we talk about higher education experts. For faculty development, our motivation for learning, transfer of knowledge, curriculum design, student assessment, all these principles may be the same, but medicine is slightly separate. There is a mismatch between medical faculty needs and educational experts' needs. See, this is what? See, there was a big discussion going on whether